faithfully conveying value, interpreting the world's best books. Hello, this is Sally's Book Talk. Today's book for you is If We Have to Leave, with the subtitle about aging, death, and peace. When prolonging life and reducing pain conflict, which would you choose? Welcome to Leave Comments and Share Your Views. In traditional views, a doctor's duty is to save lives. If a disease can be cured, that's best. If not, they should find ways to prolong the patient's life. But with the times changing, many are starting to think that death is inevitable. If prolonging life means increasing pain and greatly reducing quality of life, could one choose to stop treatment? To face death in a more peaceful way, the author of this book, Samuel Harrington, is an honors graduate of Harvard Medical School. As an internal medicine and gastroenterology doctor, he practiced in Washington for over 30 years. After retirement, he focused on writing and promoting medical reform. In hospitals, Harrington saw many doctors use aggressive treatment, with prolonging life as the primary goal, using surgery, medication, and other methods to treat diseases to the maximum extent. Harrington found that aggressive treatment often causes a lot of pain for the elderly, even leading to complications that result in earlier death. During his medical career, Harrington also experienced the deaths of his own parents. They did not choose aggressive treatment, refusing surgery to prolong life, but instead opted for palliative care, aimed at improving quality of life. Palliative care typically uses medication to control the condition and reduce pain without seeking to cure the disease. Both lived peacefully in their final years and ultimately chose hospice care. They passed away surrounded by family. These experiences made Harrington realize the limitations of medical interventions and start thinking about how the elderly can better spend their final days. This book has 12 chapters and 230,000 words, aimed at readers aged 65 and above, as well as relatives caring for the elderly. In the book, Harrington discusses the harms of aggressive treatment and offers his advice on how the elderly can face death. Harrington is not encouraging the elderly to refuse aggressive treatment. How to treat is each person's right. He hopes that the elderly see that there are other choices besides aggressive treatment when facing death. By comparing different choices, the elderly can spend their final days in a way that satisfies them, embracing death. But I'll break down the main content of this book into 3 parts for you. First, what harm does aggressive treatment cause to the elderly? Second, how do diseases lead to death? Third, how to prepare for facing death. Let's start with the first part. What harm does aggressive treatment cause to the elderly?
The author believes doctors have 2 responsibilities: prolonging life and reducing suffering.
Most of the time, these responsibilities don't conflict. But as patients age, the conflict becomes obvious and even irreconcilable. This is because elderly physiological functions decline significantly. For example, heart muscle fibers age and die, weakening the heart's ability to handle stress. Decades of fat and cholesterol build up narrow blood vessels, impairing circulation and making vessels stiff. If seniors have habits like drinking or smoking, long-term alcohol and nicotine exposure further reduce kidney and lung function. Additionally, elderly immune systems are more fragile, making recovery difficult and increasing vulnerability to bacterial infections. These physiological changes make aggressive treatment outcomes unpredictable and potentially harmful to seniors. A common example is CPR. When the heart stops, doctors perform it as emergency treatment, but CPR offers limited effectiveness for the elderly while causing significant pain. Medical statistics show frail seniors have less than an 8% chance of surviving CPR and being discharged. DCPR requires forceful chest compressions, and fragile elderly bones often fracture ribs. Bone fragments can pierce lungs and chest cavities. Even when revived, many seniors remain unconscious, ventilated, tubed, and permanently comatose in ICUs. Because of these CPR issues, many elders explicitly refuse it with their families and doctors. If the heart stops, let nature take its course. Like CPR, many surgeries offer limited benefits but cause substantial harm to the elderly. During his career, the author saw dozens of seniors develop gastroinflammatory bleeding from anti-inflammatory medications and blood thinners required for surgeries. Many elderly people become extremely weak after surgery and can only rest in bed. Some develop complications like pneumonia from prolonged bed rest, increasing mortality risk. Studies show late-stage lung cancer patients choosing palliative care actually live longer on average than those opting for aggressive treatment. Similar findings occur with late-stage breast and pancreatic cancers, as aggressive treatment causes greater suffering. This may be unbearable for already frail cancer patients. Additionally, surgeries, medications, and medical tests pose risks to the elderly too. First, medications. Frail elderly bodies may suffer severe side effects from drugs effective in younger adults. The author encountered an 80-something ulcerative colitis patient with frequent diarrhea and incontinence who learned of an immune-altering new drug through ads. Eager to try it, but the author advised against it given his age. Research on its side effects in seniors was scarce, making risks high. The author recommended letting his body gradually adapt to the colitis. While colitis often spontaneously improves, the patient and family insisted on the new drug. A specialist consulted also endorsed the new drug. Soon after the first injection, his bowel symptoms significantly eased, but this improvement was short-lived. Within 2 weeks, he was in the ICU. The drug severely disrupted his immune system, causing dysfunction and lung infection. After 2 weeks struggling in ICU, he passed away. Next, physical exam risks. Some procedures are inherently painful and harmful, with greater dangers for seniors. Colonoscopy screening is a prime example.
Conventional wisdom says removing colon polyps prevents cancer, hence regular screenings to detect them early.
After decades performing colonoscopies and polyp removals, the author grew skeptical of this view. Modern colonoscopies detect polyps under 1 millimeter. Screenings are widespread, yet colon cancer mortality hasn't declined. The author has also encountered patients whose colonoscopy screening showed nothing abnormal, yet they developed colon cancer within a few years. The author believes colon polyps are just one of many causes of colon cancer. No one can definitively say how much colonoscopy screenings actually reduce colon cancer incidence. Meanwhile, colonoscopy screenings pose clear risks to the elderly, causing discomfort and pain, sometimes leaving seniors weakened. Colonoscopies may also cause splenic tears, occurring in about 1 in 100,000 cases. Some people naturally have their spleen adhered to the colon. Straightening the colon during the procedure can tear the spleen, causing massive internal bleeding.
The author now advises against routine colonoscopy screenings for the elderly.
Colonoscopies should only be performed if there's evidence of colon abnormalities. After discussing these issues with aggressive treatment, the author isn't rejecting it, but wants seniors to recognize its limitations. Much medical advertising fosters unrealistic optimism about technology, creating the illusion that aggressive treatment can always restore health and prolong life. Scientists believe that in societies with good health care, average human lifespan is about 85 years. As physiological functions decline with age, aggressive treatment becomes less effective and more harmful. At a certain stage, aggressive treatment inevitably does more harm than good for the elderly. All right, to summarize part one, for seniors with significant physiological decline, surgeries, medications, and exams may cause harm or even hasten death. Death is inevitable. Even advanced medicine can't sustain life indefinitely. Everyone must consider, since death is unavoidable, how do I want to spend my final days? Avoiding this question by believing aggressive treatment alone can sustain life often leads to wasting precious family time in hospital beds while suffering unnecessary harm from aggressive treatment, potentially dying sooner. The author believes planning ahead for one's final chapter and transitioning to palliative care at the right time avoids such harm, allowing a peaceful departure on one's own terms. So when should seniors consider stopping aggressive treatment? To answer this, we need to understand how death occurs. Now, in part 2, we'll discuss how diseases lead to death. According to CDC data, chronic diseases cause 90% of deaths in Americans over 65. Hence, this book's focus on chronic illness. We'll now explain how 4 common chronic diseases cause death. First is congestive heart failure, accounting for 34% of elderly American deaths. And now, high cholesterol diets cause atherosclerosis in many Americans, which kills heart muscle cells and damages cardiac tissue. When damage accumulates sufficiently, it causes inadequate heart blood supply, leading to heart attacks, while triggering lung and kidney failure. This condition is called congestive heart failure. Heart failure treatments include medications, valve replacements, or pacemaker implants. But these only work temporarily and can't cure heart failure. As patients age, heart problems recur more frequently, even after temporary stabilization from treatment. The condition soon worsens again. When elderly patients enter this recurring illness cycle, the author believes it's time to consider stopping aggressive treatment. Specifically, if a senior is hospitalized for the 4th time or 2nd time within a month due to heart failure, aggressive treatment offers minimal benefit. They can start planning their final chapter. The second common chronic disease is cancer, accounting for 28% of elderly American deaths. Cancer encompasses hundreds of diseases, all characterized by uncontrolled cell growth. Cancer causes death through various mechanisms. Some die from bleeding, others from malnutrition. Brain metastases cause swelling and death. Most cancer patients have weakened immune systems, making them vulnerable to fatal infections like pneumonia. Early-stage cancers often respond well to treatments like surgery, but for late-stage cancer, neither surgery nor chemotherapy helps meaningfully. They only add suffering.
Clinically, cancer is staged from 1 to 4 based on tumor size and metastasis.
If cancer reaches stage 3 or 4, indicating widespread metastasis, the author recommends stopping aggressive treatment and switching to palliative care. The third common chronic disease is chronic obstructive pulmonary disease, COPD, accounting for 9% of elderly American deaths. This category includes various chronic lung conditions, most commonly emphysema and bronchitis, all causing irreversible lung damage. There aren't effective cures for these lung diseases. Typically, antibiotics manage symptoms and prevent worsening. Well, as patients age, lung damage worsens. Breathing requires tremendous effort, causing weight loss and weakness that confines them to bed. Patients also develop antibiotic resistance, diminishing medication effectiveness. Ultimately, patients may die from respiratory failure or other pulmonary complications, similar to heart failure. Like with COPD, patients enter recurring illness cycles in late stages, losing basic daily functioning. At this point, patients and families should consider stopping aggressive treatment. The fourth common chronic disease is stroke, accounting for 8% of elderly American deaths. Most strokes result from reduced brain blood flow, primarily due to atherosclerosis. Strokes cause uncontrolled limbs, facial paralysis, or speech difficulties. Severe strokes lead to coma or death. Current treatments are limited. Medications may relieve a current stroke but can't prevent recurrences. Most strokes aren't fatal. Patients partially recover but never fully regain prior function. With recurring strokes, physical decline progresses until bed confinement weakens immunity, inviting fatal complications like pneumonia or blood clots. When seniors experience multiple strokes with significant decline, they should consider planning their final chapter. Note: each senior's health status and disease progression differs. The author provides general suggestions only. Any medical decision requires thorough discussion with your primary doctor. Patients and families should ask doctors, what's the success rate of aggressive treatment? What potential harm could it cause seniors? They also need to understand the concept of median survival. Median survival refers to the time by which 50% of patients die under current conditions. For example, 10 months for late-stage lung cancer. This means half of late-stage lung cancer patients die within 10 months of diagnosis. Patients and families should ask about outcomes with versus without aggressive treatment. What are the median survival estimates for each approach? For many terminal illnesses, median survival differs little regardless of treatment choice. The author knew an 89-year-old with stage 4 pancreatic cancer. Her doctor stated median survival was 3 to 6 months, with or without chemotherapy. Hearing this, the woman felt enduring chemo's pain and side effects during her final months wasn't worthwhile. She declined aggressive treatment. Some might think median survival means half die before this point, but half live longer. 50% odds don't seem bad.
Worth gambling on.
The author notes some do survive beyond median estimates with aggressive treatment. But these cases almost always involve younger patients. Elderly examples are rare. As mentioned earlier, seniors' physiological decline makes drugs and surgeries more harmful. Elders must understand that given their physical state, median survival is reliable. Data shows their remaining time will likely be slightly shorter. Base end-of-life planning on this understanding. Beyond the 4 chronic diseases, the author discusses another special chronic condition, aging itself. Even without fatal chronic diseases, no one lives forever. Over time, seniors become increasingly frail, lose mobility, tire easily, feel lethargic, and eventually become bedridden. At this stage, aging-related complications often prove fatal. The author's father exemplified this. He lived to 93. In his final 5 years, he wasn't diagnosed with any serious illnesses. He had chronic lymphoma, but the cancer cells were dormant without symptoms. He had atherosclerosis, but it never progressed to heart failure. He'd had several minor strokes that reduced hand dexterity, and as he aged, he grew increasingly frail, needing help with toileting and dressing, with noticeably reduced appetite. The author took him to many doctors who agreed his decline wasn't disease-related, but natural aging. His father accepted mortality and prepared accordingly. From age 90, he discontinued aggressive treatments and regular doctor visits, taking only blood pressure medication. 3 months before death, he stopped all medications for home hospice. His final cause was a minor stroke causing swallowing difficulties. After days without food or water, he slipped into coma and passed. The author views this as a good death. Time with family, no unnecessary suffering, a dignified, peaceful departure on his own terms. All right, summarizing part 2. Many chronic diseases can't be cured. As patients age, chronic symptoms worsen, entering recurring cycles causing complications. At this stage, patients or families should discuss stopping aggressive treatment with doctors. Even without severe chronic illness, seniors eventually die from natural aging. Facing death isn't easy. Patients often need time to accept this reality. Ideally, patients prepare psychologically early, allowing ample time for end-of-life planning. Now for part 3. How to prepare for facing death.
The author presents 2 preparation methods. First is the end-of-life conversation, discussions between seniors and relatives about final arrangements.
These conversations cover all death-related topics. For example, when illness becomes terminal, choose aggressive or palliative care. Where does the patient want to spend their final days? Should they receive hospice care? What final wishes need fulfilling? The author believes end-of-life conversations should start as early as possible. Some relatives wait until seniors are seriously ill when they may psychologically resist discussing death. These conversations can be tough. Some elders refuse to accept reality, end up choosing aggressive treatment, die prematurely, and miss their preferred departure. Truly regrettable. So even if seniors aren't seriously ill, the author advises starting these talks early. But since elders rarely initiate these talks, relatives must take responsibility. Relatives shouldn't expect to settle everything in one or a few conversations. If started early, end-of-life discussions become an ongoing process spanning years.
So relatives need patience, finding everyday opportunities to advance these talks.
Not every talk needs a firm conclusion. Just getting elders thinking is progress. Conclusions will emerge gradually. Any health-related topic can spark these conversations. For example, when friends or relatives are hospitalized or pass away, Discuss choosing between aggressive and palliative care. Ask seniors how they want to spend their final days. If elders experience health issues, falls, memory loss, or strokes, relatives can discuss long-term care. Started early enough, relatives will find many opportunities. Even with initial resistance, seniors gradually lower defenses and become willing to plan. Additionally, relatives can involve doctors for professional analysis and advice. As talks progress, seniors develop clearer wishes about treatment, care, and where to spend their final days. Relatives can then have lawyers formalize these wishes into legally binding living wills. The benefit: if seniors lose communication ability due to illness, relatives and medical staff can follow the living will, ensuring their wishes aren't violated. In the U.S., many seniors carry their living wills. The author's mother wrote one. He specified that once comatose with unrecoverable brain function, he refused CPR, assisted ventilation, dialysis, and requested caregivers to hasten death through dehydration and starvation. The second preparation method for facing death is hospice care, which aims to reduce suffering in life's final stage, allowing peaceful, comfortable departure from this world. The author details hospice care in the U.S. context. In America, hospice is a well-established service with specialized agencies providing care, whether patients are at home, hospital, or nursing facility. U.S. regulations require doctors to certify life expectancy under 6 months for hospice eligibility. Many assume hospice brings a full medical team, but actually, relatives or hospital staff provide most daily care. Hospice supplies, equipment, medical supplies, 24/7 phone support, and scheduled weekly nursing. For the author's father, hospice provided specialized beds, oxygen tanks, catheters, urinals, plus pain and sedative medications. As he weakened, they installed a lift to transfer him from bed to chair. Typically, hospice nurses visit weekly to manage medications and assess health. As decline accelerates, nurse visits increase for frequent medication adjustments and family care guidance. Relatives can call for immediate support during emergencies. If needed, hospice provides round-the-clock personal nursing care. Ultimately, hospice replaces burdensome hospital visits and treatments, sparing patients from meaningless interventions and needless suffering, enabling them to be with loved ones while facing death peacefully. To the author, this constitutes a good death. Most hospice advocates believe patients need at least 3 months to fully benefit. Regrettably, many access hospice far too late. Statistically, the median survival for hospice patients is only 1 month. The author helps relatives won't shy away from hospice discussions and will help elders understand its benefits. That way, when needed, elders can receive hospice care as early as possible. All right, to summarize part 3, facing death, people can prepare in 2 ways. First, end-of-life conversations where relatives and elders discuss final arrangements. The earlier these conversations start, the better. When conclusions emerge from these talks, they can be formalized into a living will. Second is hospice care, which mainly provides equipment, medical supplies, 24-hour phone support, and regular nursing. Through hospice care, patients reduce unnecessary suffering and can depart in a peaceful, comfortable manner. With that, we've pretty much covered if we have to leave. So the author believes everyone must understand that death is inevitable. By accepting it, people can better plan for it. In the face of unavoidable death, what matters most isn't fighting it relentlessly, but living fully to the end, closing life's chapter with dignity and calm. After listening to this episode, what new views do you have on death? Feel free to leave comments below. All right, that wraps up our interpretation of If We Have to Leave for you. Listening notes are under the audio. See you next time.